All right, let's dive into the core of what we do in orthopedics. Before any surgery, before any treatment plan, it all starts with one thing: propaedeutics. It's the systematic workup, our roadmap that takes us from a patient's complaint to a precise diagnosis. If you're going to go into this field, mastering this process isn't just a good idea, it's everything.
So here's our game plan. We're going to walk through the diagnostic journey just like you would in the clinic. We'll start with the big picture, the workup itself. Then we'll get hands-on with the clinical exam. After that, we'll look inside the body with imaging. And finally, we'll see what labs and joint fluid can tell us. And at the end, we'll wrap it all up with the key messages you absolutely need to remember.
First things first, let's talk about the overall orthopedic workup. This isn't just about ticking boxes on a form. This is the logic, the cornerstone for every single decision you're going to make. You really have to think of yourself as a detective first, before you can even think about being a treater.
So what is propaedeutics, really? Well, it's our playbook. It's the methodical process of gathering all the clues from the patient's story, from your own exam, from initial tests, and using them to build a list of likely suspects, your differential diagnosis. This system is what separates a wild guess from a solid evidence-based conclusion. And that whole process really kicks off with the most important tool you have, the clinical examination. This is where the real detective work begins, combining what the patient is telling you with what you can see, feel, and observe with your own senses.
Now, the clinical exam isn't random. It's built on these 6 pillars. Think of it as a systematic checklist that keeps you honest. We always start with the patient's story, the anamnesis. Then we use our senses, aspection, just looking, followed by palpation and percussion. From there, we get objective with measurements and goniometry, and then we wrap it up with specific, provocative tests. Following this structure means you're thorough, every single time.
Anamnesis, or history-taking. This is where you become a storyteller, piecing together the narrative. The chief complaint might be the headline, but the social history, what they do for work, for fun, gives you crucial context. The character of their pain clues you into the pathology. And of course, their past medical history can completely change your approach. Every single one of these pieces is a vital part of the puzzle.
Okay, I need you to burn this next slide into your brain. This is a golden rule, a non-negotiable in orthopedics. The patient's unaffected side is the perfect built-in control. A finding on the injured side means almost nothing until you've compared it to their own normal baseline. Always, always compare bilaterally. All right, so once we've squeezed every drop of information out of the history and the physical exam, it's time to look under the hood. Imaging lets us go from observing things on the surface to actually seeing the internal anatomy, and more importantly, seeing the pathology. Now here's a really critical point. You don't just order an image. That's not how it works. You have to choose the right tool for the job. The big question you have to ask yourself is, what am I trying to look at? Bone or soft tissue? Because the answer to that question will tell you exactly which imaging modality to choose. And this table just lays it out perfectly. Let's break it down. Your X-ray? That's your workhorse. It's the first step for looking at the big picture of the bone. It's fast and it's basic. Now, if you need to see really intricate 3D bony detail, maybe for a complex fracture going into a joint, that's when you'll turn to CT. The trade-off? A much higher dose of radiation. But if you suspect a soft tissue injury, a torn ACL, a damaged rotator cuff, something going on in the bone marrow, then MRI is the undisputed champ. Nothing beats it for soft tissue contrast. And beyond those big 3, we've got some more specialized players. Ultrasound is fantastic because it's dynamic. You can see tissues moving in real time, and it's great for spotting fluid collections. Scintigraphy and PET/CT are all about metabolism. They light up areas that are highly active, which is perfect for finding hidden tumors or infections like osteomyelitis. Then you have arthrography, where we inject dye right into the joint to highlight structures like the labrum in the shoulder or hip. Okay, let's switch gears and move to our final set of tools. Laboratory analysis gives us a window into the body's internal environment. We're talking about systemic processes like inflammation, infection, or metabolic issues that can show up as orthopedic problems.
So when you order a panel of labs for your patient, what are you actually looking for? What kind of clues can their blood work give you? It's not just a random screen. Every test we order has a very specific question we're trying to answer.
It helps to think about these tests in a few different buckets. You've got your general inflammatory markers like ESR and CRP. Then you've got markers of bone metabolism, calcium, vitamin D, which give you a sense of bone health. We also have immunological markers like rheumatoid factor or HLA-B27 that can point toward autoimmune conditions. And of course, a classic one, a high uric acid level. which is a huge red flag for gout.
But, sometimes blood work isn't direct enough. Sometimes you have to go straight to the scene of the crime. And that is exactly what arthrocentesis or joint aspiration is. We're literally putting a needle into the joint capsule and pulling out the synovial fluid to analyze it directly.
And let me be perfectly clear about this. This procedure is absolutely vital. If you are ever faced with a single joint that is hot, swollen, and exquisitely painful, you have to suspect infection. And aspirating that joint isn't just helpful, it's mandatory. It is the #1 way to rule out septic arthritis, a true orthopedic emergency where every minute matters.
Okay, we've covered the whole workup from the moment the patient walks in the door all the way to sticking a needle in their joint. Now, let's boil all of this down into a few high-yield principles that you can take with you and use in your daily practice.
Principle number 1, and you've heard it before, always compare bilaterally. It's the simplest, cheapest, and often the most revealing test you have. Your patient is their own control.
Second, don't overthink it at the start. Despite all the fancy high-tech toys we have, the standard 2-view X-ray is still the foundation of imaging. For the vast majority of bone and joint issues, you start here.
Principle 3. Know what your tools are for. If your gut is telling you this is a soft tissue problem, a ligament, a meniscus, a tendon, an X-ray isn't going to cut it. For soft tissue pathology, MRI is king. Period. And finally, our fourth principle is all about clinical urgency. A single hot, swollen, painful joint is septic arthritis until proven otherwise. And how do you prove it's not? You aspirate that joint. It's a diagnosis you simply cannot afford to miss.
So, I'll leave you with a final thought to chew on. When you find yourself in a real diagnostic dilemma, a truly confusing case, where does that aha moment usually come from? Is it hidden in a tiny detail of the patient's story, a subtle finding on your exam, or is it that one surprising lab result? Think about where the most crucial clues are usually found. Thanks for joining us.